Good God. You know, I'm multitasking. I'm on Instagram. I'm alive. What do all these buttons do on Instagram? Let's not go there. Let's just press the button. Oh, the video's working. Yes, good. Right. Yeah, we're live. We're going. We're cooking. We've got a Q&A going on here. It seems like ages since I've done it. I'm currently in costume. Not sure if you've noticed the difference because I'm doing a murder mystery this evening and I'm hosting it, so I am the host with the most, and yeah, that is live. But in the middle of it all, so I've done a bit of prep and now I'm doing this, and then I'm going to go and do the starter. So in the middle of it, we're doing this Q&A right here, and we've got ourselves some cues. Jackie's on side as always. Cocoon's here. Good to see you. Hope you're doing all right. Webster, how you doing? Right then, so whew, I'm a little bit hot and bothered because I've been running around, but anyway, let's see what we got here. I've got me some questions, but if you've got a question burning a hole in your pocket, then just get it off your chest and get it on the screen, and I will do my level best to address it with my extensive library of knowledge. So first up, we've got, do we offer tongue reconstruction surgery? Funny question this. I don't really know the context of these questions, so perhaps you could argue I should know the context of them, but is what it is. We are where we are. Let's not dwell on the past. So I don't really know what this question is referring to as tongue reconstruction. So I'm going to assume, unless the person who asked the question is out there, in which case they can come back at me, but I'm going to assume that this is talking about tongue tie, because that's the most common operation that we get involved with as plastic surgeons. And tongue tie is where the frenulum of the in the middle, you know, that holds your tongue down, goes too far forward, and so the tongue can't get your tongue out. And that is something that is released by plastic surgeons. That is something that we do as plastic surgeons, but it is usually done in children. And so I haven't done it in many years, and I wouldn't be allowed to do it, to be quite honest with you, because you have to be a pediatric plastic surgeon to operate on children, and we couldn't do it at the clinic. And so I'm going to say no to that. We don't offer tongue reconstruction or tongue tie surgery simply because we haven't got the kind of approval from the CQC. We have got surgeons who are pediatric plastic surgeons, and we have got a pediatric nurse, so we have got stuff in place, but the main thing, we haven't got the CQC, so we don't operate on children, and so we don't often tongue tie surgery, if that is indeed what you mean by tongue reconstruction. As I said, that's the most common thing. So yeah, it's a relatively simple thing, and I think they often do it in the clinic, in the outpatients, because it's done on very small children, and it's quite a simple procedure. But sadly, not at Shay New. Doing brilliantly, thanks. Thank you for the card. Thank you for the card as well, Cocoon. Right back at you. So yeah, give and receive, give and take. So looking forward to seeing you soon and seeing how it's all going. But yeah, you're very welcome. How do you correct over liposuction on inner thighs? Oh, blimey. Do you know what? This question, I've not seen these questions before. I'm seeing them live. This is, you know, reacts to questions. This question kind of like, what is it? Well, to be honest with you, I don't do liposuction of the inner thighs, so I know it's not my patient. So in that respect, it doesn't. I was going to say it sort of sends shiver down my spine, sort of alarm bells ringing, and thinking, oh my God. But in some ways it doesn't, because it's not my patient, so that makes it feel better to me, but still I feel bad for the patient, because the answer to the question is extremely difficult, and without knowing anything more about it, just the question saying how do you correct over liposuction on inner thighs, I would say really hard. You're really hard, and this is the problem. Indeed, the problem with plastic surgery, or maybe any surgery really, probably, is like it may be a cliche, you know, to say it's better to get it right first time, but it is so hard to fix things which aren't right. And in terms of liposuction, you've got two options of it not being right. And that means you do too much or you do too little. Now, if you do too little and there's still some fat there, it's relatively easy to go back and do a little bit more. But if you do too much, that is hard, and it's much more difficult to fix an overcorrection than it is an undercorrection. And you understand why people get overcorrections, because we're trying to help patients and we're trying to give them a good result. So, you know, we're trying to, obviously we don't want them saying, oh, you haven't done enough and you're a rubbish surgeon and I don't notice any difference. You know, you don't kind of want that kind of reaction. So you obviously want to have a tangible difference for the patient, but at the same time, overcorrection is worse, and it's a very difficult problem to correct. And personally, I don't do liposuction of the inner thighs, simply because the skin is very thin and the skin doesn't recoil, and you get quite, and it's possible to get, you know, quite difficult irregularities of the skin, skin folds to excess skin there. So, you know, it's, I guess the only way you could fix, well, one way to fix it would be to do a thigh lift if that patient was a candidate for a thigh lift, but not many patients are candidates for thigh lifts. You have to have quite a lot of excess skin there to be a candidate for a thigh lift. And the bottom line is really tough to treat over liposuction. Sometimes there's a tendency to think, oh, should I do a bit more liposuction? Because the over liposuction is kind of like a dent. And if I can get rid of some of the fat on either sides of the dent, either sides of the mountains on either side of the valley, and make the valley a bit more shallow, maybe I can make it a little bit better. And that's something certainly on table that you can do when you have a patient. You think, oh crikey, I've over liposucked that. But it's a difficult, dangerous game, because then you can get into badness if you sort of overcorrecting an even bigger area. So that's a dangerous game. Probably the most sort of straightforward way of doing it would be fat grafting. Hi, Corinne. Would be fat grafting into the dent. I'm assuming the problem is a dent. When you're saying overcorrection of liposuction, I'm assuming that means you're a dent. You got a dent. So fat grafting into the dent. But that sounds great, doesn't it? Just, oh, I've taken too much fat, stick some fat back in again. Sounds great. The problem is that dent is scar tissue, and you try and inject fat into the scar tissue, and what happens? It doesn't like going into scar tissue. It goes into the nice soft tissue on either side, and you make the actual mountains bigger, which makes the valley look worse. So it can really be a real problem of trying to fix an overcorrection of a liposuction, and there is no easy answers. And what I would the advice I'd probably give to this patient, without knowing anything about them or what it looks like or what have you, is think carefully about going down that route, because we always worried that we could make things worse. You've had too much liposuction, you've got scarring there, which is causing the contour irregularities. Presumably, as I say, I haven't seen them, you know, I'll be something specific about the case, but, you know, usually that's the common problem. And it's really hard to get rid of scarring. And to be honest with you, the best thing is time. And time will let that scarring soften and hopefully lift up the dent, and maybe to make the contour irregularities look better. And they certainly will look a lot better, you know, a year than they would at kind of 6 months. So, you know, that I guess that's my best advice, because doing more surgery to correct over liposuction is difficult, and it's a difficult area, and there's no easy answers. I don't even know what the answer is. I've given you two, you know, liposuction out of the mountains, but then you can potentially get a wider area of overcorrection, or fat grafting into the defect, but then the fat can go to the path of least resistance and making the dent look worse. So both of them, I would be really worried about doing either of them. And, you know, I just, you know, it sounds, again, you know, don't get into that situation. As a surgeon, you know, do everything you can to not get into that situation, because you don't want to be there. It's really difficult saying to a patient, oh, you're better off leaving it and hopefully it'll get a bit better. And, you know, they've obviously not got the result they want, but it's a difficult position to be in, and really tough one there. Corinne, what are you saying about hair? I saw something about saying about hair transplants. Yeah, no, I'm in costume, Corinne, not hair transplant, but we pretty they haven't matched up the color quite right. But I'm in costume, Corinne, because we're doing a murder mystery thing tonight, and I'm hosting it, so I've got to go and be the host. But I've had to. I'm preparing we're doing well, it is a murder mystery, but it's a come dine with me type thing with the family, and tonight's my night. It's supposed to be long story. I know you're going to say, why did you do it on a Tuesday night? I know you're going to say that. I think the same thing. It's supposed to be last night, but then my wife's went out, never told us, and I'd already prepared the the dessert. I prepared the dessert for last night, so I'll eat it anyways tonight. So that's what it is. Do we offer axillary breast tissue removal? Yes, we do. That's probably be wrong to say it's common, but it's not uncommon. Is that the same as common? It's not uncommon the same as common? Anyway, I wouldn't say it's common, but I would say it's not uncommon. It's a not uncommon procedure. Axillary breast tissue removal is not uncommon, and it's bumps of tissue here in the armpits and in the area there, and it's known as axillary breast tissue. Often sort of comes up over the bra. People sometimes don't know it's there and kind of hope it's going to get better with a breast lift or a breast reduction, but it doesn't, because you don't address those areas with those operations, and it has to be addressed directly, either with liposuction or excision. Pros and cons of both. Liposuction is good because you don't get scars, but doesn't remove skin, so you potentially have some spare skin there. So if you want to get rid of the skin, then you have to excise it, but then that could give you a visible scar at the front, so that's a negative of that. So liposuction or excision are the two potential options for that. Something to discuss on a case-by-case basis as to what's right for you. Brilliant, love it. Did wonder about the tie combo. Not feeling it. I'm one of the wealthiest, Rico's business partner, and one of the wealthiest men on the island. That's my role I'm playing tonight. So yeah. So there you go. Millionaire, playboy, businessman. There you go. Do we treat burn scars? Do we treat burn scars? Now, there is a subspecialty of plastic surgery, which is burns, which is not my subspecialty. My subspecialty is breast. And I would probably say for a significant burn scar, it probably would be a burn surgeon who would be best. I mean, it kind of depends on what the problem is. I mean, so burn scars are very hard to make look better. So it's usually a functional surgery when you're treating burn scars, and you have to make sure you've used non-surgical means to start with, like pressure, and potentially silicone if they're hypertrophic scarring, maybe steel injection if there's sort of lumpy scars. So there's kind of a few things that you can do previously. Usually the problem with burn scars, aside from the cosmetic, as I say, we can't really do a significant improvement on cosmetic, unfortunately, at the moment. There's not huge amount you can do, but you can do things here. So usually it's when they're crossing joints and you get contractures, arms, elbows, hands, neck, wherever it may be. So tight skin and tightness, particularly when it's crossing a joint. And certainly there are things you can do to try and import some skin to make the movement better and to improve the tightness. But they're usually quite difficult operations because you're moving skin about, often in scarred areas, and so you've got to be very aware of the blood supply of the skin. And it's probably, for any significant burn scar, I would say a specialist operation that you would want a specialist burn surgeon for. One of the things I talk about in my book, oh yeah, that bad boy, that we're all different. You know, you think plastic surgeons, or let's get him to do the boobs. Not all plastic surgeons are breast surgeons. There are head and neck surgeons, burn surgeons, hand surgeons, quite a big area, pediatric plastic surgeons, craniofacial surgeons. So there's different types of plastic surgeon, and that would be a burn surgeon who would be better suited, I would say, to treat that burn scar than me, for instance, who is primarily a breast surgeon. That's my primary subspecialty interest. I have 2 young children, 3 months and 20 months, and I'm considering a mummy makeover. When will we be able to pick, hold the children, etc., after having the surgery? Right, okay, that's a good question. So what I normally say to people, it's a big surgery, a mummy makeover. It's usually a breast and a tummy operation together. It's a big op. It will set you back. Guaranteed it will set you back. And what I normally say is, if you've got a job working in B&Q or working in the Amazon warehouse or something like that, I would say 6 weeks before you do any heavy lifting. Now, if you have small children, you can't really not pick them up or not not hold them and things for 6 weeks. So it's a bit different than if you're doing a job. So if you're doing a job, I say no heavy lifting for 6 weeks. If you've got a small child, then I say, well, you will have to pick up your child. Or almost certainly you're going to have to pick up your child. Great if you've got help and all that sort of stuff, but you've got to assume you're going to have to pick up your child. So the two things I would say is 6 months is kind of like the minimum before people suggest that you start having this kind of surgery. I normally say a year is better, because a year the child is a bit more mobile and maybe a bit less needing to be picked up. Although I accept he probably will be wanting to pick it up and help. But what you normally do is you adjust. So you sit down and you put them on your lap rather than picking them up from standing and things like that. So so it doesn't matter what I say. If I say after surgery you can't pick them up for 3 weeks, there'll be situations in the first 3 weeks where you'll probably have to pick them up. So I would say, look, don't worry. Listen to your body. If you might not be able to, it might be too sore, and you might say, look, it's too sore, I can't pick you up. But if you're able to, just adjusting, get to a seated position and then pick them up, or get them to come to you, sort of thing, rather than picking them up from a standing position. And what you're going to do is you're going to make it swell. That's the reason for all this. You're going to make it swell. So just try and take it easy, and maybe think about having the surgery a bit later on when potentially your child's walking and things. That's why usually 12 months is better, although obviously the child will be bigger and heavier, so that's something to take into account. Sue has commented. I didn't see that. Sue, how you doing? You're rocking that wig. Thank you. Recovering well. Many thanks for doing a good job. Oh, thank you, Sue. That is great to hear. Thanks for the comment. And yeah, I don't think I've really got the wig. I got a couple to choose from, and I was in a bit of a rush choosing this one. I'm not sure if it was the right one, but anyway, I'm going to work with it because time waits for no man. So yeah, thank you. Kind words indeed. Don't really think you mean it. I don't know if I could go out into the public like this. Do you think? I look like a politician who looks like he's got a wig on. He was on Blind Date. Who's that? You know that guy? Anyway, don't want to cast aspersions now. Don't want to be libelous. Fat transfer versus breast implants. Google fight. Fat transfer versus breast implants. Who will win? Well, on paper, there's a lot to be said for fat transfer. I like fat transfer. I do a lot of breast implants, but I am a massive fan of fat transfer. And I used to do it every week when I was working in the NHS, when I was doing breast reconstruction after cancer. I think it is a fantastic technique. It's brilliant. I love doing it. It's great. The scars are small. The risks are low. There are risks, but they're low. And it's when you get a good result, it's a long-lasting result. It's your own fat. It's fantastic. It's happy days. And I'll be honest with you, if I could, I would do it all day long instead of breast implants, because there are potential risks with breast implants. They're rare, but they're there. And that, if you get problems with breast implants, feeling the edge, seeing the edge, rippling, moving, malposition, all these sorts of things. There's all sorts of problems with breast implants that are out there that you would not have with fat transfer. Having said that, it is extremely rare to do fat transfer. Sometimes I get people who say, I want fat transfer for breast implants. I have to look for a photo from about 10 years ago to show them a case of mine. Literally, I would say, 10 years ago, the last time I did fat transfer, certainly for a breast augmentation to make both breasts bigger. It's very rare for me at the moment. I think people are trying to do it and trying to make a thing of it. And, when they have to remove implants, sometimes they put fat in to try and, if patients got an issue or something, the reason they don't want breast implants, and then those patients might think, oh, that's really great, I'm really happy with it. But I think when you critically look at the results of fat transfer breast augmentation, the results are really subtle. And as I say, you have to go back a long way to see cases when I've done it. And if you look at it when I've done it, it looks really subtle. You have to kind of analyze the photograph to say, can you see it's a bit more? Do you see? Look at the pre and post op. Is it a bit more? And you know what? It's never good when you have to convince a patient they got a good result, when you have to show them their before and after photo and say, look, haven't you got a good result? You want the patient to walk into the clinic and say, oh my God, I feel fantastic. I look great. I feel fit my clothes much better. And I feel great. You don't want to have to take a photograph to convince them they've got a good result, which is what I find personally in my personal hands. And in my personal experience of doing fat grafting, it is very subtle. So you're looking at, And the problem is also people having breast implants are often quite slim. The donor sites are limited. If they're not slim, then their breasts are often bigger, so you often need a bigger volume. So it's kind of lose-lose situation. But the sort of volume of fat I'd be looking at, if I put 80 mils in, that'd be a lot. And the smallest implant you're going to use is about 150, 200, and you're often using 250, 300 cc implants, which means if you want to get the same sort of volume with fat, you have to repeat it. You have to do it, and you have to leave it like 4 to 6 months and do it again and do it again. And it's almost as expensive as doing implants. So if you need 4 operations for fat grafting, which you can get in one with an implant, it's a difficult one to say that's going to be a good thing. And as I say, patients who want it are often quite slim with limited donor sites, and so it's not as good as you might think at first sight. So in the Google fight, it's implants winning at the moment. Hands down, it's a knockout. I've got to be honest, it's a knockout. And I wish it wasn't. I'm a big fan of fat transfer, but at the moment, when you weigh out the pros and cons, the price and the subtlety of fat grafting just makes it not a viable option in my view and in my patients, much as I would love to spend all day, every day doing fat grafting, because it's a lovely thing to do. And I love the fact that it's small scars and small complications. It makes you sleep a lot easier at night, but it's a cross I have to bear. I have to keep doing implants personally, in order to get significant results for my patients, because it's much as you sleep at night doing the surgery, you would wake up in the morning and have to go and see the patient, and you'll be stressed because the patient's then saying, "What have you done? What's happened there? Is that it?" So that's more stressful. Factually, that is more stressful than the stress of the surgery by far. Dealing with patients who are not happy. So that's why I try and manage the expectation pre-op. And then you can imagine I have the conversation which I've just had with you just now with patients who are then say, well, forget it then, mate. I'm going to have implants, or I'm not going to have anything at all. If they've decided they don't want implants, I'm like, well, that's fine. I'd much rather not do anything at all than have a patient who's paid £5,000 or whatever. I don't know what it is, but it's probably, it's that sort of order. I'd rather have not do anything at all than someone who's paid £1,000 who then says, "What have you done? That's rubbish. It's not happy." So that is not a place you want to be as a surgeon in this world. If you can at all avoid it. So no, stay in. Whoa. Right, I'm going to go and do my starters now, unless there's any questions. You've got any questions about it? It's a nice bit of interaction, largely about my Urdu. But if you have, next week, pretty sure I'm not on holiday next week. I'm on holiday again at some point, but I will be available, I'm pretty sure, next week, Tuesday night, and that is, have a great night, good luck, make sure you look after my boss tomorrow, please. She's coming to see you. Oh my God, Corinne, you should, if you hadn't said that, I would have known. I'm getting nervous now. Which one is it? Oh my God, Corinne's boss is coming. Oh my God. Right. But don't worry, Corinne. I'll tell you what, I'm going to look after everybody tomorrow just to make sure that we cover your boss. All right. So yes, fantastic. Not like usual. Fantastic. And yeah, starters await. Avengers Assemble. So I'm going to be signing off, and I'll see you same time, same place. Salma wants a tummy tuck so bad. With how many O's is that? That's 4 O's. Well, Salma, you're looking at the tummy tuck guy. Call me. Thanks, Corinne. Thanks, Jackie. Yeah, I do tummy tucks, Salma, if you're interested. So yeah. Call me and we can sort something out. 0121 454 3680. That's my number. Well, it's not my number, it's the office number, but I think it's probably on the Instagram somewhere, I guess, on the profile, is it? Or email or message or whatever. Anyway, good. Well, thanks for coming, Salma, and I might see you soon. And without